So today I'm going to discuss with you a cell therapy that is likely going to be a way to treat chronic ischemia in the future, in the near future, I hope. I'm going to show you human data only. This is unusual, and it's backed up by proteomic and cytometry data on each patient. I'm going to show you angiograms. I'm going to show you some clinical pictures that are some of it is pretty graphic, and I'll discuss some mechanistic discoveries that we made. So anybody that thinks cell therapy doesn't work needs to recall that they started from an ovum and a sperm, two cells with half the nuclear content of a regular cell, and that resulted in you and me. That is the first mitosis. And this is the end result. So anybody that doesn't believe in cell therapy, we can see the forest. We may not see the trees, but the forest is obvious. And guess who was not involved in making the 60,000 miles of vessels in that baby? It's 60,000 because it's not just large vessels, it's all the capillaries, venules, arterioles, and all that. By the way, that goes around the Earth 2.5 times, and it goes 1/4 of the distance to the moon. Guess who was not involved? A vascular surgeon. And I'm a vascular surgeon. So this is the obvious motivation for the work that I've done. So why vessels? Just briefly, oxygen and nutrients need to get to cells. The longest distance that oxygen can transport itself in the absence of a vessel is only 200 microns. Cells will die if they're further than 200 microns from a capillary. Vessels are very complex. Somehow nature does this. And if you come for my next lecture, which is in 2 more lectures, you'll see some of the physics behind this. But a lot of the vessel is to give it strength so it doesn't rupture. And keep in mind, as you are getting taller and bigger as you grow up, your vessels are growing with you, every single one of them, both in length and diameter. And guess what they don't do? They don't rupture, even though it is highly pressurized. And I can say that for a fact because if you accidentally injure a vessel, the blood will hit the ceiling in the operating room. So highly pressurized, and you need all that protection. But the full function of this organ is in a 1-cell layer thick called the intima, and that's where the endothelial cells are. So that's the action part that keeps the vessels open for your lifetime. That can get damaged by disease. So the engineering challenge is, first of all, when there's a disease, is to try and fool Mother Nature by making new avenues, or let Mother Nature do it by arteriogenesis. And that refers to making the main avenues. Those are the ones you can see readily in the operating room or on an angiogram. Then there are the side streets. That's called angiogenesis, making the side streets. And then, of course, there can't be any bleeding. You have to have arterial-venous continuity because it's a closed vascular system. And as you're growing, these vessels have to grow through tissue. So it's got to penetrate the tissue matrix. Very hard to do. So I'm a vascular surgeon. My job is to fool Mother Nature. That means make some external bypass around all the blockages. And the other thing we do is like make a new channel through the artery itself by using atherectomy or balloon angioplasty. We put stents in. But you know, I'm going to tell you, as a vascular surgeon who's done 16,000 cases, that is not the way to treat this disease, in my opinion. The best way to treat this disease is at the tissue level. So this is probably the first time you've heard of this. It's called tissue level revascularization. That's what we're calling it. And the strategy we used is very straightforward, but it's to address lots of problems. So I'm going to list the problems here that we address with two straightforward approaches. Multi-level arterial occlusive disease impairs endothelial cell activation. What does that mean? Well, when you have multi-level blockages, the velocity of the blood is so impaired by the time it gets down to the below knee level, it's almost like dripping. You can see that under ultrasound. The velocity is so low. And the problem is to make an endothelial cell turn on to promote arteriogenesis or vessel growth, you need endothelial shear stress. It's not there when you have multi-level arterial occlusive disease. You also need the oxygenated nutritive inflow. That's impaired, obviously. You have to clear toxic metabolites. Otherwise, the biochemical milieu where you're trying to make biochemistry happen at the tissue level, it's not going to work because proteins denature when the tissue is hypoxic and acidotic. You need the protein distress signals in the tissue to be able to get out of the tissue and get into the general circulation. Unfortunately, when you have multi-level arterial occlusive disease, the rheology for that isn't there. Those distress signals stay there. They don't travel effectively. And if they do travel and get to the bone marrow, bind to the CXCR4 receptor, as we heard earlier, the mobilized proangiogenic cells that are supposed to come and rescue the problem, they don't get there because as they come out of the bone marrow, they travel all over the body, except where the problem is because there's too many blockages in the way. So those are the hemodynamic obstacles we wanted to attack. Then with advanced vascular disease, there are some special issues. One of them is the progenitor cell pool goes down as we get older. And those are the cells we need to promote, that's our fountain of youth. It promotes tissue repair. We need a growth factor pool. That's diminished because of the absence of the progenitor cell pool. One of the things that happens in vascular disease, which usually is from plaque is segmental, usually at bifurcations of vessels. But as a stenosis or narrowing gets tighter and tighter, the blood flow diminishes and you develop thrombus. And thrombus becomes chronic thrombus and just sits there. So even though the disease is at the top of the vessel, the entire artery below that will thrombose and it just sits there. We could use agents to dissolve that clot that are readily available, but they're very dangerous. So we can give it for 2 hours, for 2 days, and that will dissolve clot. But anything longer than 2 days, which is usually the case when it's chronic thrombus, the risk of bleeding in the brain and in other organs go up. So it is not an option. But if one can find a way to sustain physiologic fibrinolysis or clot breakdown, which is a normal biological process that we all have, and keep it going without being turned off, which is what the body always does when it starts, it stops it so we don't bleed to death. If one can sustain that for a period of time, one could potentially clear slowly this clot without creating side effects. And the last thing, of course, is the immunity in advanced vascular disease is diminished. And you need that to heal chronic vascular wounds. So how do we address these? If you look at that, these are the 8 or 9 problems that we formulated our approach. And the approach we took today is going to be very simple, but I think it will get refined as more people jump on board with this kind of work. The first thing is we put a pump on the leg while the patient's seated. So it's like putting a heart below all the obstructive disease and restoring the shear stress stimulus, improving oxygenated blood flow, clearing toxic metabolites, and so forth. So they have to sit during the day for 3 hours minimum, and at times more than that, because they actually find benefit just wearing it in terms of their symptoms. And then for all these complicated issues down below, we just give them a single shot, and we do it at an unusual dose. We give them granulocyte colony stimulating factor, and patients give themselves their own shots subcutaneously, and they do it once every 3 days for a total of 10 doses is what we've used, which would give you essentially a month of therapy. So what is G-CSF? Filgrastim is the one we use. It's made by Amgen, but there are others. G-CSF increases the absolute neutrophil count. That's its primary FDA-approved indication. It's used after cytotoxic chemotherapy to restore acute cellular immunity. It's got another benefit. It increases the circulating progenitor cell population. So it actually is a driver of getting whatever bone marrow stem cells you have out and flooding the system. The question that we are trying to do, so we want to change the label of the product because it doesn't talk about vascular disease. We want to know what is the impact of an increased neutrophil count is on neovascularization and on fibrinolysis. And we want to know if this drug can actually address the CPC deficit in patients with vascular disease. These questions had no answer because all the clinical trials using this drug in vascular disease never spent the time doing the molecular work and the cytometry work in humans to actually see what was being accomplished. So this is a neutrophil. The neutrophil is schizophrenic. The neutrophil is very complicated, like many of the cells are in the body. These are electron micrographs, and this is just an artist's rendition. It starts off as a myelocyte in the bone marrow and matures all the way down to a polynuclear cell. And how does it work? Well, it can degranulate, it can eat bacteria and tissue and chronic thrombus. And what was discovered more recently by oncologists and hematologists is that as the cell is becoming apoptotic, it will release its chromatin, which is a very active structure. It's a trap. So it can trap bacteria, but that trap also contains a lot of enzymes. So neutrophils release molecules with opposing actions depending on the situation that the neutrophil finds itself in. Nobody's ever really studied what happens to a neutrophil in the setting of ischemia, which is the setting of my patients. And by the way, vascular disease is the most common cause of health problems in the Western world, between heart attack, stroke, and peripheral vascular disease. Also, neutrophils release molecules that influence other cells. So let's talk first about the duality of neutrophils related to angiogenesis versus anti-angiogenesis. Now, interesting, when people started using this drug, it was to take advantage of the progenitor cell boost. They were aware the neutrophils went up, and if you look at the original papers, they'd say, well, we don't know what the neutrophils really do, except that the literature up to that point said they were anti-angiogenic and prothrombotic, which is exactly what you don't want in a vascular patient. It's only the work of hematologists, oncologists, and this study that showed that there's two sides to a neutrophil. So that red column there was generated from data that is since we first did our clinical trial. These were some of the proteins that we measured. And it turns out neutrophils release all of those, and they're pro-angiogenic. Second of all, the ones that inhibit angiogenesis are the ones that are all over the literature antedating our work. And then there neutrophil elastase, which has a horrible reputation in the world of vascular because of not understanding the molecule until now. And then neutrophil extracellular traps, that's only recent information. And it turns out both of them have pro and anti-angiogenic effects depending on the context. So neutrophil elastase we'll talk about since it had the worst reputation as being bad for vascular people. It actually is pro-angiogenic and it's elicited in an ischemic environment, that property of neutrophils. It cleaves regions of pro-angiogenic factors. It enhances their pro-angiogenic impact. Neutrophil elastase stimulates the migration and proliferation of endothelial cells by degrading the extracellular matrix. Remember how I mentioned that's important. And also degrading collagen and fibronectin, which results in fragments being released that activate the integrin signaling pathway in the endothelium. Now, this is the opposite of what Dr. Nagy talked about earlier. He hates M2 macrophages because M2 macrophages are not what you want in a cancer. But M2 macrophages are what we want in vascular. So a polar problem, just like everything in oncology is polar to vascular. So neutrophil releases interleukin-1 beta and GM-CSF, which polarize macrophages toward the M2 phenotype, and we like that. Why? Because it induces angiogenesis, which cancer doctors don't like. M2 secretes VEGF, which you probably all heard of, and FGF is fibroblast growth factor, which is a potent pro-angiogenic molecule. M2 macrophages also participate in tissue repair and immune regulation. Now, this is another property of neutrophils that's really cool. They eat stuff. They eat impaired cells, they eat degraded tissue, they eat bacteria. But when you eat things that are not good, that are dying or dead, what do? You actually clear debris so you can improve oxygen utilization by the remaining viable cells. And that makes tissue repair and angiogenesis a lot easier. Now let's talk about the chromatin. Chromatin is, as you know, the DNA. It gets released as a neutrophil is dying. Neutrophils have a short half-life, so if you flood the system with neutrophils, you're going to get a lot of NETs. And this is great work by oncologists and hematologists. So these webs, they interact with the endothelial cell surface receptors to promote endothelial cell proliferation and migration. And that's exactly what you need for neo or new vessel formation. Now let's talk about the other side of the coin, anti-angiogenic factors released by neutrophils. Endostatin, angiostatin, these are potent molecules. They're antagonists of endothelial cell proliferation and tube formation. They directly target our favorite cell, the endothelial cell. They disrupt the extracellular matrix and they impair the scaffolding necessary for new vessel formation. Arginase 1 dampens the proangiogenic T cell activity. And the NETs, you can't see it down below there, but they actually also have anti-angiogenic potential. So let's go back to this protein that was so notorious, the neutrophil elastase. That definitely is anti-angiogenic. It cleaves endothelial cell growth factor receptors, the receptors, disrupting the sprouting and maturation of new vessels. And they also degrade the extracellular matrix and fibronectin, which hinders the scaffolding necessary for vessel growth. Now, interestingly, there's an experimental approach right now to use allophane and silvostat to block this enzyme. And that promotes neovascularization in tissues. So you can actually directly interfere with neutrophil elastase. Now we're going to switch gears. We're going to go from angiogenesis to something we discovered totally by accident. When we looked at angiograms of patients treated with this drug, all of a sudden I was seeing segments of arteries that were previously occluded, they were visible. So we measured things like plasmin and fibrin degradation products, and they were elevated. This was a major turning point, and you'll see the angiograms in a minute. So in any case, it turns out neutrophils have fibrinolytic and antifibrinolytic properties. Those have been worked out since our first patients were done. The green column are all the enzymes that promote fibrinolysis. The brown column are all the ones that inhibit alpha-2 antiplasmin and plasmin activator 1, plasmin activator inhibitor 1. And there's the NETs again, the traps. They have both effects. So neutrophils release that neutrophil esterase and cathepsin B, which degrade fibrin and plasminogen. They release urokinase type plasminogen activator, which directly converts plasminogen to plasmin. Neutrophil myeloperoxidase generates the reactive oxygen species that can activate plasminogen, bypassing the need for TPA. And here's that enzyme again, neutrophil esterase and cathepsin G. They generate fibrin fragments that plasmin can further break down. And then the NETs can store plasminogen, creating a localized pool for plasmin to be released from. So all these are pro-fibrinolytic. These have all been characterized in the past 10 years. How about antifibrinolytic? That means favoring clot formation. Well, alpha-2 antiplasmin has been known for a long time to be a potent inhibitor of plasmin activity. It prevents excessive clot breakdown. Plasmin activator inhibitor 1 inhibits TPA-mediated plasmin generation. And the NET chromatin can limit plasminogen's accessibility to the activators, which hinders fibrinolysis, and the histones on the NETs, that's chromatin, can directly inhibit plasmin activity. So how do we answer the question when you have a schizophrenic neutrophil and the neutrophil goes up 6,000%? Right? It goes up dramatically when you give this drug. I'm sorry, 600%, not 6,000%. So we took 14 patients, typical age for vascular disease, sex was male and female equal. Indications for enrollment is that they had to sign a consent for amputation because each of them had already exhausted all the normal revascularization options. You'll see why in a second. And they were coming in because they were going to have their leg cut off, and we were going to enter them in this trial. All of them had ischemic rest pain, and that's like unrelenting pain, day and night. At night, it's worse because their blood pressure is lower. They have to sleep sitting in a chair to get just gravity to help blood trickle down. They're miserable. And a lot of them had ulcers and gangrene. So 39 total failed bypasses were done in 14 patients. And if you think each bypass is $100,000, that's a lot of money on 14 patients. Their comorbidities and their medications were no different than other people with severe vascular disease. The assessments we did was we looked at ischemic wound healing, symptom abatement, angiography, before and after. We measured their hemodynamics before and after. That means recorded their blood flow. And we used all these techniques. We did the blood test. This is what's unusual. We did ELISA, that's sensitive, as most of you know, to the picogram per ml level, 10 to the minus 12 gram level. We looked at neovascularization related proteins, and we looked at fibrinolysis related proteins. We also looked at endothelial activation by using the device by itself. We measured serum nitrite, which is a reflection of endothelial activation. And we did cytometry to see the impact of the drug in these ischemic patients. Because unlike cancer patients, these people came in with a normal neutrophil count. So we weren't really sure how high the neutrophil count would get. And then we did a cell blood count with differential. In the cytometry group, we also measured the progenitor cells, the CPCs. So this is a normal angiogram. Remember that picture, because none of the patients you're about to see have any of that. They're in because their vessels are all blocked up. So let's look at patient 1, 56-year-old who had a gangrene of his forefoot. To heal the amputation you see there, he had to have a bypass. The bypass went on to occlude. After it occluded, the stump became ischemic and started to open up, and eventually the entire thing opened up. His blood flow should be pulsatile, like you see up there in the top of the picture, but down below, his ankle brachial index, which is a measure of perfusion, was 0, and the waveform was flat. So there is nothing ever that I have seen as a vascular surgeon that would suggest that this is a solvable problem without surgery again, which he was not a candidate for. You'll see why that is in a second. In any case, we entered him in our protocol. He was the first patient we treated. Look at the pulsatility down in his foot when we got to the 8-month point, and his ankle brachial index was 0.64. That's what his foot looked like after we cleaned him out in the OR from all the gangrene and necrosis. This is as the wound is healing. This is when it's healed at 8 months. And this is his angiogram before. You don't see any of those nice vessels you saw on the normal angiogram. And this is what it looked like at 6 months when we did an angiogram, which was part of the protocol at that point. So all those corkscrew type collateral vessels, you can see now, they're grown. This is the second patient, worse than the first one. She had multiple bypasses. She was obese. She had diabetes, impaired hepatic function, and she had really nasty wounds that I'm going to show you in a second. She had her leg for 12 years afterwards, and after that, we lost her to follow-up. But this is day 1 in the ankle level. That wound doesn't heal even if you have normal blood flow. And this is, the other wound is in the front of her leg. And this is her. We took this picture 2.5 years later. That was totally healed. And this totally healed at 9 months. Now, interesting, she got enthusiastic about the fact that she didn't lose her leg, and she started walking a lot without protecting her foot. And this is what happened. She got an injury to her toe. Now, that doesn't look too bad, right? But in actuality, it is very bad because she has no blood flow in that toe. So if we didn't re-enroll her, she would have lost the toe. In fact, she would have lost her leg because she wouldn't have healed a toe amputation. That's her 1 year after we treated her the second time. So this is what she came in with. You can see the blood flow is just as bad. And 3 months after we treated her, it's you can't see the numbers here, but the ankle brachial index went from 0.4 to 0.5. This is when she stubbed her toe, and we've already treated her the second time, and she's starting to get better pulsatility, and her ankle brachial index is up to 0.7. 1 is normal. And this is when it's 1, which is at 22 months, and you can see pulsatility there. But what is really impressive are these pictures. These are the pictures that changed my life and made me take the whole project to the University of Chicago to use their core labs to do all this proteomic work. So these are toe pressures. They should be all pulsatile. These are all flat. This is when we re-enrolled her, and it was still pretty flat. And the rule in vascular surgery is you don't ever get pulsatility back on its own. When it's gone, it's gone. All of a sudden, 2 months after we treated her the second time, she has pulsatility in her first toe, just spontaneously. And this is almost a year later, she has pulsatility in all 5 toes. So let me show you now the clinical pictures. The angiogram. The angiogram before, you can barely see any vessels. These are after failed bypasses. The anatomy is a bit altered. Very hard to see anything. This is 1 year after we treated her the first time, and you can see all this collateral flow. And you can see segments of arteries that were previously occluded open. And between her and the previous one, that's when we discovered that we stumbled on fibrinolysis potentially. This is the third one we entered on compassionate use at the same time as the other lady. This is a hypercoagulable patient, which is the worst patient for vascular, because no matter what you do to them, their graft will thrombose. And they didn't know that when they did her 2 bypasses, and then they did 2 catheter interventions. And what's really interesting is that hole on the top of her foot was from a puncture from a needle to do a retrograde balloon angioplasty of the popliteal artery. She was so ischemic that that little puncture wound became gangrenous, and you could see gangrene in her toes. She had an ankle brachial index of 0. And again, in the experience I've had, that should never heal. This is her 8 years later. Unfortunately, that is there, but the wound that you see there is completely healed in the dorsum of her foot. And she was ambulatory. So this is her pre-op angiogram, and you can barely see any vasculature there. And her ankle brachial index was 0. This is her angiogram afterwards, showing corkscrew collaterals and ample flow into the foot. And this is the pulsatility in her great toe that didn't exist when we first treated her. So this is a major accomplishment. So based on these 3, I moved this project. And now these patients have had detailed hematological assays. And this is a very instructive patient. She's elderly, she has bad blood flow. And this was her blood flow, ankle brachial index of 0 and 0.16. And we got it to improve. But what's interesting about her is this is her angiogram, and those purple lines are little twigs of vessels. What's interesting about her is what the cardiologist did next. He did a nitroglycerin angiogram, which we didn't ask for, but he was curious. So he used a high-powered injector, full strength contrast, and the best imaging equipment in the hospital from which she was referred to get this image. And what this is showing is that all the collaterals that we're trying to grow are actually there. They're just not visible on a regular angiogram. But if you give them a vasodilating agent like nitroglycerin, you will be able to see them for about 10 seconds. Because as soon as you give the drug, all these vessels dilate. But as soon as the drug is cleared, which is a few seconds later, they're no longer visible. This is below the knee on the top and the calf below, and this is down at the ankle and foot. Now I'm going to compare these side by side. Both of those are before we treated her, and our goal is to get that nitroglycerin angiogram afterwards without having to give nitroglycerin. So we did the poor man's angiogram. So I'm a vascular surgeon. We have not as good equipment as cardiologists have for imaging. I used half-strength contrast. I gave small injection by hand, half-strength with a small syringe and a little catheter up in the groin. And this is what we saw. So in other words, we are proving the point that we are able to dilate collaterals without having to use nitroglycerin and keep it sustained, because this was without any nitroglycerin. This is further down on the knee, and this is down at the ankle and foot. And what's interesting is now we have more contrast going into the foot. This is a patient who had wet gangrene, which is infection. We had to amputate it, a wide open wound, but he was profoundly ischemic. And he had bypasses, atherectomy, laser angioplasty, all sorts of great stuff. That would not heal when the ankle brachial index as low as his was, but we got it to heal because this is what we started with. You don't see the vessels well. And in fact, in the foot, you can't hardly see anything. This is what we ended with when these wounds healed up. This is a dramatic case of a patient with a marijuana-induced vasculitis, which is like an allergy. And she came to us from Florida to Chicago with the diagnosis that she needs a high thigh amputation. And she was hysterical and suicidal. So we treated her, and 30 days later, you can see this redness developing in the foot. It's dependent rubor, but it's also the redness of reperfusion. That's 24 months after enrollment. And I recently talked to her on the phone, which is 12 years after we treated her. She's ambulatory. So why was she going to get a high thigh amputation? Well, she lost not only the artery to below her knee, but she lost the artery in her thigh. Those two red circles don't have anything in them. And that's what resulted in profound ischemia. Now, what's interesting is that her good side is on the left, my left. The bad side is on the right. You can't see collateral flow with CT angio, but her normal vessel down below was visible before the normal vessel on the left side after we treated her. That was actually right underneath that compression device that I showed you. And here, the left leg has that yellow around what's supposed to be her good vessels, but look how big her side that was underperfused, how big those vessels became. And that was visible lower down too. And this is her angiogram 2 years later. None of those vessels are named vessels, but they go from her groin to her foot. So she rebuilt a vascular network after our therapy. And I am going to show you this patient real quick. She had a vasculitis. She was treated with hyperbaric oxygen. This is related to tobacco. So after she stopped the tobacco, her wound got worse, even though it's supposed to get better. The hyperbaric oxygen didn't do anything. She spontaneously amputated her fifth toe. We got involved, and this is what we achieved. So we stopped the necrosis, and we actually got it to heal. And this is the angiogram. You can see those rich corkscrew collaterals in her ankle. This is, I think, the last patient I'm going to show you, just to show you that the device itself is not enough. This patient for 3 years wore that device, and the ankle brachial index and toe indexes did not go up. As soon as we gave him the drug, they were synergistic together, and they shot up. And this is his angiogram showing vessels from the groin to the foot. So we're almost done. We sampled blood before and after using the device for 2 hours in a supervised environment. We used the device alone as a control in 19 patients. We used the drug and the device in 14 patients, and we measured blood in the ones that got the filgrastim on day 1 and after the 5th dose and after the 10th dose. So this is the cytometry and CBC data. The neutrophil count, as you can see, went up 654% plus or minus. The p-value is 0.001. This is what the drug is supposed to do, make the neutrophils shoot up. It's also made the white count go up, which is typical, and went up 430 some odd percent. The lymphocyte and monocyte counts went up. Those are all statistically significant. You can see that column is p-value, the gray column. These are the progenitor cells, the CD34 and VEGFR2 cells, and those also went up, statistically significant. And after the 10th dose, they were up even more, and the p-values were significant. The CD31 cells are mature endothelial cells. That's the PCAM adhesion molecule. That reflects endothelial cells that were cleared into the bloodstream during the use of that pump, and their CD31 cell count went up. We measured all these proteins, these are almost the same proteins that I showed you that neutrophils by themselves were measured by the hematology research people. I showed you these earlier. And so this is a summary. We got a 10-fold increase of plasmin. This was a discovery. We got a 5-fold increase in fibrin degradation products. So that supports the fibrinolysis we observed on angiogram. We also got an increase of most of the proangiogenic serum proteins that I showed you just now, P less than 0.05 to P less than 0.00001. And none of these increases were related to the device because none of the control patients had this with the device alone. Whoop. So the new knowledge, filgrastim and CLTI makes the neutrophil count go up. We use a novel dosimetry once every 3 days instead of once every day. We developed a proangiogenic milieu and a profibrinolytic milieu. So remember that balance that you can be one or the other, anti or pro. In our case, in the ischemic environment, we were pro for both. The findings are supported by proteomic measurement, angiographic observation, hemodynamic measurement, and clinical assessment of improved blood flow. And these findings were so dramatic that we went to an independent institution and repeated this in 6 more patients and found the same results. So the new knowledge, sustained induced neutrophilia, is a new approach to chronic thrombosis, we believe. It's not proven yet because we did not have a placebo control. It's safe because we didn't have anybody hemorrhage. And we got a long period of sustained fibrinolysis, which is enough to be like a roto-rooter to clean out the chronic thrombus. And it promotes neovascularization. The other new knowledge is that pump that we use actually does activate the endothelium because the MCP1 increased with the device alone, and the nitrite increased, and the CD31 cells increased. Those are 3 characteristic findings when the shear stress, those shear stress goes up. There is synergy with filgrastim because unfortunately filgrastim makes MCP1 go down. So all the people that used filgrastim by itself for limb ischemia, they didn't get really as impressive results as we did because they didn't make the environment healthy by using an external device. But what we found is the MCP1 would go down, but as soon as we gave the device in the clinic for 2 hours, the next MCP1 level was back up to where it should be. So the next steps, further investigation necessitates measurement of these anti-fibrinolytic enzymes. We didn't do that because we didn't anticipate that discovery. And we want to know for sure, is filgrastim-induced neutrophilia a primary effector of fibrinolysis? So that requires a control, placebo control. VEGF-165B was our negative control. VEGF-165B is an anti-angiogenic molecule. It was not detected in 7 of our 8 patients. In the 8th patient, it was detected the day after the 10th filgrastim dose. And he turned out to have an occult metastatic gastric adenocarcinoma, which caused his ischemia by a prothrombotic state. And unfortunately, in our screening, which was very detailed because it's by an oncologist, that wasn't diagnosed. So he should not have been entered. But the interesting thing is, because that was detected, the decision was used to use a anti-angiogenic chemotherapeutic regimen, and his adenocarcinoma that was metastatic vanished for 1 year, but then it came back with a vengeance and he died. And so more research is needed here. Does filgrastim make some tumors produce this anti-angiogenic factor, VEGF-165B? We only have 1 patient that suggests so. Resistance to filgrastim occurs in diabetics, 15 to 20% of them. It was not observed in our small cohort. The solution is to give plerixafor, which takes care of this problem. Vasculitis, we did do patients. You only treat patients who have vasculitis after the vasculitis is over. So they have to stop the inciting cause. In our patients, it was One was tobacco, the other one was marijuana. So they have to have normal CRP and ESR. Then they're a garden variety chronic ischemia patient. In our case, it was successful. There is a question of whether this could be used for long COVID because the vasculitis results in microthrombosis of pulmonary vasculature, and that causes pulmonary hypertension. So after the COVID is done, the vasculitis is over, you have lots of small vessels in the lung that are thrombosed. And the question is, can you then use this approach? So that hasn't been done yet. Opportunity for research. Another one is the microthrombosis in the brain that occurs to diabetic and hypertensive patients. It's the rule, not the exception. So if you live long enough, you're going to get a form of vascular dementia if you have diabetes and hypertension, and it's associated with microthrombosis. So there is a possibility that we may be able to help there too. Diabetic wounds, filgrastim-reduced surgical intervention, amputation, and hospitalization in a Cochrane review of diabetic foot infections without chronic ischemia. In the management of limb ischemia with wound infection, that needs to be investigated, another opportunity for work. And then there's the issue of using other agents or devices. So one is to use a long-acting GCSF, like a pegylated form, using hyperbaric oxygen with it, using anabolic agents with this approach to help promote growth of tissue, like growth hormone or anabolic steroids. Epidural stimulation is associated with some improvement by itself with ischemia. And the other thing is the device we used was a device on the market. It wasn't engineered to activate the endothelium, but it was the best I could find because of its rapid inflation time. And it's actually used in the UK, on the Irish side of the UK, very effectively, the device. But different amplitudes, different frequencies. And the other mechanical force transduction methods can activate the endothelium, like ultrasound or vibrational stimuli. And we need a placebo-controlled trial because the previous trials of filgrastim in the leg and in other circulatory beds like the coronary will need to be revised at a dosimetry that capitalize on two things they did not know about: fibrinolysis and the molecular impact on neovascularization. So I think this is the last slide. The placebo-controlled trials, you need a switch and you need electricity to get light. The switch is you have to activate the endothelium and make the environment healthy to initiate and promote arteriogenesis. And the electricity is to improve the body in terms of progenitor cell counts and the fibrinolytic potential. You have to optimize that environment. Thanks.